All right. Okay.
Blessings, sir.
Our blessings.
Where is everybody from? Where do you guys live?
Most likely Nigerian.
Nigeria, yeah. Igbo or Ubi?
Yoruba.
Yoruba. I used to have one of my soccer coaches growing up for a long time was Nigerian. Bruce Ofuwani in Tallahassee, Florida. He's a great dude. I really loved him. So I think he was Igbo, and he was a great soccer coach. I played with him for years. Fortunately, he passed away, not from colon or rectal cancer, so that's good. Do you guys live in the States or?
Okay. Yeah, we're about to start now, Doctor.
Okay.
Okay, let me just acknowledge you first. Let me say good afternoon to everyone. And welcome to today's health education seminar organized by Eko Club Philadelphia. My name is Bola Okoya. Before we begin, I kindly ask all participants to observe the proper Zoom meeting etiquette to ensure a productive and enjoyable section. This includes muting your microphone when not using it. Hopefully raise up your hand if you have any question, and also try to minimize any distraction. And this is a good way for all of us to enjoy the seminar we're here to listen to today. To kick off this event, I'd like to introduce the president of Eko Club Philadelphia, our amiable Honorable Olabisi W. Okoya. If the president is here, can you wave your hand and let everybody acknowledge you? Hopefully, probably coming in later. Under our leadership, Eko Club Philadelphia has championed impactful initiatives such as the Ronald McDonald House, Adopt the Highway, Thanksgiving, and Turkey Giveaway, and also we do Winter Coat Drive, as well as scholarship. And this is our new initiative right now, the health education that we are doing every week, once a month. We partner with Capital Health. Is one of the biggest hospital within the Mercer County, Burlington counties, and within the area of New Jersey. Is one of the big hospitals here. So we are very happy that we are partnered with them. This is our second section with Capital Health. Hopefully another one is coming up in January 11. So stay tuned. We have so many packages for you from Capital Health. Thank you so much, Capital Health. And thank you so much. And I would like to give you the overview of our presenter today, Dr. John Smith Berry. Hold on 1 second. Let me just look at the resume here. Very impressive resume. Now it's my pleasure to introduce and give the biography of our esteemed speaker for today's seminar. Dr. John Smith is an experienced board-certified fellowship trained colorectal surgeon with a focus on minimally invasive technique. Dr. Berry is committed to providing personalized treatment plan and ensuring patients receive the highest standard of care. His clinical interests include Synfista, if I pronounce it right, please correct me. Synfista, right? Preserving technique for advanced rectal cancer and enhanced recovery protocol that allow patients to experience shorter, safer hospital stay and less time away from work. Dr. Berry received his undergraduate degree in chemistry at the United States Military Academy in West Point, New York, and went to receive a military honor as an armored cavalry officer for dedication and valor in combat operation. After his service, in the Armor Cavalry, Dr. Berry received his medical degree from Jefferson Medical College of Thomas Jefferson University in Philadelphia, Pennsylvania, where he received the Francis Torrance Stewart Clinical Surgery Award and was inducted into the Alpha Omega Alpha Medical Honor Society. He completed his general surgery residency at Brooke Army Medical Center at Fort Sam Houston in San Antonio, Texas, where he was a research fellow of the Institute of Surgical Research and served as a chief resident. Dr. Berry was fellowship trained in colon and rectal surgery in Washington University in St. Louis, Missouri. Before joining Capitol Health, Dr. Berry was an colorectal surgeon in U.S. Army base at Fort Liberty, North Carolina. During this time, he served multiple deployments to the Middle East, where he was chief surgery of combat hospital in Sinai, Egypt, and Doha, Qatar. Dr. Berry was also division chief of colon and rectal surgery at Womack Army Medical Center in Fort Bragg, North Carolina. A gastrointestinal surgical oncologist at Caromount Regional Medical Center in Gastonia, North Carolina, and an associate professor in the Department of Surgery at Uniform Service University of Health Science in Bethesda, Maryland. Dr. Berry is a fellow of American College of Surgeons, a member of the American Society of Colon Rectal Surgeons and the Society of American Gastrointestinal and Endoscopy Surgeons. In his free time, he enjoys embarking on adventure with his family, coaching soccer, and nurturing his love for gardening. Please join me in welcoming Dr. John Smith Berry to lead us in important discussion. Dr. Berry, we are eager to hear from you. The floor is yours. Thank you. Can you hear me? Can you hear me?
We can hear you, but we don't know if Dr. Berry heard you. Dr. Berry, are you still there?
Can you unmute, Dr. Berry? Can you unmute? You unmute. You're muted. Can you unmute?
Yeah, oh, I can. Thank you for giving me permission to unmute. And what a beautiful introduction. It's been a long history and a lot of moves. So thanks for having me here today, Bola, and thank you to the Eko Club of Philadelphia for allowing me just a few minutes to talk to you about colon and rectal cancer. I have to be fair. I did not. I may not have done this at the right level of education, but if I don't, I'm going to leave time in between topics for people to ask questions, and you can always put your questions in the chat too. Okay, and Bola, if you keep me honest as the moderator to kind of address those questions, I'll stop at certain points where those questions may be more applicable than just at the end going all the way back. Okay.
Okay, good.
Again, thank you very much. I really appreciate the opportunity. I have been around the world a couple of times, as I'm sure most of you have, and it's always a pleasure to be with kind and caring folks. And thank you. I appreciate it. So I'm going to share my slides. We'll get into colon and rectal cancer, a comparison between the two. We'll kind of do some anatomy and things like that. and then we'll learn a little bit about it together. Of course, I'm learning every day, and I'll bring some of those points up to you. So let's see what I can do. Share my screen, send request, and the request has been sent. We can share. So let's see if I can share. And here we are. I'm going to share this. And this is my slides. And let me push play. Now, I assume everyone can see that. Can I just get a verbal check from somebody that everyone can see that and hear me?
Yes.
Okay, perfect. All right. So, like Bola so eloquently said, I'm here to talk about rectal and colon cancer, or colon and rectal cancer. I work in Hopewell at Capitol Health Hopewell. We have another hospital in the middle of Trenton called Regional Medical Center. I do cover that hospital, but I don't operate there. My office is here. My partner's office is here. Our gastroenterologist and colon and rectal cancer team are here, and the cancer center is here. So this is the place to go. Sometimes people go to the wrong hospital, but this is it. And it's really pretty. So welcome if you come. These are kind of the topics today. We'll take them as they come. We won't spend too much time on any one topic. I'm just going to pull the chat up here and make sure I'm doing okay. Here's the chat. Good, perfect. And let's see if I can move that chat somehow. We're failing there. Do you guys see the chat? It's kind of right in the middle of everything. Let's see. There we go. It's off. All right. So these are kind of the topics, and we'll go from here. What I want to talk about is what is the colon, what is the rectum. They're all kind of lumped together sometimes. Maybe we'll just do a little bit more broader definition of kind of what lives in the abdomen, and then we'll talk about cancer, screening for cancer. And how we do that here in the United States, and how you can lower your risk. And we'll talk about some surgical innovations that are near and dear to my heart. So, let's see. All right, what is the colon? So this picture on the left side of your screen, it shows your colon. If you look kind of in the background, you can see a stomach, you can see a liver. That's up here on the upper right. And maybe I can draw on this. Ooh, this will be fun. Maybe not. And then you can see the colon going up from the cecum. That's the first part of the colon. It's underneath where the small bowel comes into the colon. And then the ascending colon, because it goes up your body, it ascends in your body. The transverse colon, which goes across the body. The descending colon, the sigmoid colon, because it looks like an S. And then the rectum. You'll notice on this picture that you can already see that the rectum is different from the colon. The rectum, it doesn't have that muscular line along it. It has a bunch of muscle around it. And that kind of plays into what the rectum does. The colon and the rectum have an organ that brings blood flow to it. That in the colon, it's called the mesentery. And if you look at this picture in the center of the screen, you can see the mesentery. There are arteries and veins in the mesentery. There are lymph vessels in the mesentery and lymph nodes. And so that is an important organ in colon cancer. It's an important organ for getting nutrients to and from your small bowel and colon. And it's called the mesentery. It's not something we talk about a lot, but it is very important. If you look below that picture in the middle, you see you see a specimen with colon cancer in it. Now you see this black mark. This is a tattoo placed by the gastroenterologist at the time of colonoscopy from inside the colon. And it says, Dr. Berry, this is where the tumor is. This is what you need to take out. Now, you can also see that yellow part on the kind of the right side of that. And that is the mesentery. It looks fatty. It's got a bunch of stuff on it, but that's where all the lymph nodes are. Okay, and that's important when we treat colon cancer. If you look even further to the right on your screen, the colon lays on the back, and the back is where your kidneys are. The back is where your aorta is. The back is where and the aorta brings the blood to your legs. It brings the blood kind of from your heart to all your organs. And then the return, kind of the partner of the aorta is called the inferior vena cava, or the vena cava. And you can see that's in blue, and that returns all the blood flow to your heart. So the colon kind of sits against the back, hangs into the abdomen, and has a bunch of vascular structures associated to it, like arteries and veins. If you look at that bottom right picture, what you see is me peeking underneath the mesentery and looking at the tube that carries urine from the kidney to the bladder, and that's just gives you a sense of where the colon lies in your body. Let's go to the next slide. I'm working on advancing my slides here. Hold on 1 second. Oh, here we go. I'm sharing. Okay. What is the rectum? So the rectum is the end of the colon. You can see that transition in the picture on the right. It has a muscular structure around it, and it's related to the anus, right? The anus is what keeps your stool in your rectum. It's what controls it when you want to release it. It senses when stool is present. Okay, but the rectum itself is the organ above the anus. Okay, and what you see in the middle picture is the rectum is related to other structures. It abuts and is right behind the uterus and the vagina, and then but in front of the uterus and vagina are the bladder, and it sits in the pelvis. It doesn't sit in the abdomen. A little portion of it does, but not all of it. It sits down in the pelvis, and the pelvis is outside of your abdomen, and so it's almost a different compartment. And then on the picture on the top right, you can see there's no mesentery for the rectum. There is called a mesorectum, and that's this fatty area behind the structure, and you can see it. The things on the right sometimes label it, but you see on that photo where it says mesorectum and points to that fatty yellow structure behind the rectum. And then the rectum sits on the pelvic floor. And that picture below shows that. There's the anus and the pelvic floor musculature that you can contract when you do Kegels, or you can contract or relax when you're on the toilet. And the rectum sits just above that. You're looking up from the bottom at the rectum. In addition, the rectum drains not only to the mesorectum for lymph nodes, but also to these pelvic organs, and you can see that on the right side there. These pelvic lymph nodes are important in rectal cancer, And they really are playing an increased role as we continue. So we talked a little bit about the anatomy in these two slides. Let's talk about the function of each of these. All right, the colon receives fluid from your small bowel. Your small bowel extracts all the nutrients, the protein, the carbohydrates, the fats. All these things are extracted in the small bowel. And then they're processed by the liver, and they enter your bloodstream either via the liver or via lymph flow through the lymph vessels, which is kind of a structure of vessels in your body you don't hear about that much. The colon's job after it receives that fluid is to act as something that takes water in. It's just taking the water out of the stool and forming the stool. You say, well, what good is that? Well, I mean, water is not always easy to come by. So, that's why you have your colon. It kind of works like a kidney, believe it or not, where it brings in water, it helps you retain water. You'll notice on this picture on the left side of your screen that the colon has a lot of these purple cells on it. And these cells turn over quite frequently. And that cell turnover, those epithelial cells turning over, make it more prone to having cancer because there's more opportunity with faster turnover for genetic mutations to arise. The other thing that lives in the colon is bacteria, and that bacteria kind of plays a relationship probably more than we as doctors and medicine professionals understand. We know it makes vitamin K. We know it breaks down the remaining stool to feed the colon. So it gives the colon its food, the bacteria does. And so that's kind of what goes on. It can that's where people talk about the gut microbiome or they talk about probiotics. This is what the bacteria load in your colon is what people are talking about changing or talking about maintaining. And those medicines, that research revolves around your bacteria in your gut. And when they say gut, they mean colon. And then as you look at the layers of the colon, you see there's some muscles that help move things along. There's some blood flow to keep those cells alive. And then again, there's bigger muscles that help propel things along, the muscularis propria. And these layers, they have medical significance, which we'll talk about later, but they also have just common sense significance too. And on the right, you see the rectum and the colon. So you see the dark structure that's kind of making that bird's beak, if you will, on the right side or from left to right. That toucan there is the rectum. You see that the rectum is bigger. It accommodates stool. It allows you to store stool. So people who don't have their rectum anymore, they can't store a lot of stool. They have to go to the bathroom, and they have to go to the bathroom now. The top part of that picture is the colon, and you see that portion of the you can see the width of the colon is much smaller than the width of the rectum, and that's because the colon doesn't distend like that. So different functions. One is to propulse stool, to pull water out, to feed bacteria, to maintain itself. And one is to store stool and to evacuate stool. And so that's why they're a little different. The good news is they're both screened with colonoscopy. And I'm going to talk a little bit about screening. when I tell you about screening, I'm telling you not about cancer, but I'm telling you about maintaining good colon health and rectal health. And so if you have cancer, you have cancer. Screening's not for you. What that is then surveillance, right? What I'm talking about is picking up cancer before it starts. And so in preparation for this, I looked up, I said, hey, what's cool about colon cancer screening to ChatGPT? And I learned something new. And the first thing I learned is that screening can prevent 68% of colon and rectal cancer deaths. Colon and rectal cancer is one of the top 3 cancers in terms of affecting people in America, and it is becoming more and more prevalent as we kind of I want for lack of a better time, pollute our environment. And I think that's putting a lot more people at risk. And you see colon cancer and rectal cancer becoming more prevalent in young people. And so we need to kind of be aware of this for our children, for ourselves. And fortunately, we have a way to kind of prevent it. So normally people get screened at 50 years old. That has changed in the last few years. It's gone down to 45. It probably needs to go lower. But the screening program that the U.S. Preventative Task Force put into play works. I mean, it does work to decrease the rates of colon and rectal cancer. Even with that screening protocol, 1 in 23, 1 in 25 men will be diagnosed with colon and rectal cancer. I know hundreds of people, and that means I'm going to know 10 people that get colon and rectal cancer, and that's too many for me. And so we need to kind of advocate for screening on time and appropriately based on risk. And I hope that you'll do that with me. I'm here today partially for that reason, because I think it's important for people to know that you need to get screened for colon and rectal cancer, just like you get screened for breast cancer, or you get gynecologic visits for cervical cancer and vaginal cancer. This is one of the things you have to do to prevent this from becoming an issue. And if you do, it does. And so that's easy. It's getting everyone to do it that's difficult. When you find a colorectal cancer earlier, it's easier to treat. When you find it very early, you find just a polyp. And a polyp is simple to treat and safe, okay? We've found in the United States that minorities are more affected by colon and rectal cancer because they're usually not getting screening. And that's a problem that medical professionals, including the American College of Surgeons and the AMA, are trying to improve, and trying to address. And that's one of the reasons I'm here today. So again, we talked about colon and rectal cancer. These are similarities. They start as a polyp, and then they kind of grow. And I'll get into that a little bit later, how they grow. But they grow into the wall of your colon, and you can see how they grow into the wall of the colon with these pictures on the first line here. There's stage 1, there's stage 2, there's stage 3, there's stage 4. And these are growing deeper and deeper into the colon wall. And then after that, the cancer kind of picks up a mutation that allows it to leave the colon, float into the lymph channels, grows into the lymph channels, and go to the lymph nodes. That's called regional disease. And that's one of the reasons we take out your lymph nodes. Somewhere, and not on every staging thing, is cancer in the blood. These are called circulating tumor cells. We've only been recently able to measure these, maybe in the last 20 years. And we don't know how to build those into staging quite yet, but the surrogate for circulating tumor cells or cells in your blood is cancer cells in your lymph nodes. And we've been able to look at that for 40 or 50 years. And then there's sometimes metastatic disease, where it goes just like the nutrients would go from your colon or from your small bowel into your liver, right? That's where the nutrients go. The cells go the same direction, and they can metastasize to your liver or to your lungs. But that is less frequent. And we talked about this shortly, but what happens is these cells turn over. When they turn over is a complex process. When there's complexity, there's room for mistakes by just the very definition of that. And then the cells pick up small mutations, right? And you can see up top on the right, there's blue normal epithelium, no changes, right? That cell is dividing. There's no genetic changes. And then it picks up a change. It picks up the APC change. And it starts more rapidly dividing. And then there's increased complexity. Picks up another change. You start to get polyps. Adenomas are polyps, essentially. And that is where colonoscopy picks up these adenomas and removes them and prevents people from getting colon cancer. And that's why colon cancer screening works.
Can I ask you a simple question quick?
Yeah.
Yes, talking about this colon cancer, what is the recommended age for someone to start screening?
So right now it's 45, and I'll just caution you, the age is one part of the decision, one part of the data. The other is what is your risk, right? So if your parents had colon cancer, you're at a higher risk. If you have blood in your stool, you need to go get a colonoscopy. You're at high risk, right? So it's average risk for average individuals 45 years old. But your risk may change that recommendation from 45 to another age, but never beyond 45 or never older than 45. Does that make sense?
Yes, makes sense. Thank you.
Yeah, no problem. Thank you for asking. Is there any other questions in the chat?
No, no,
We'll keep
no question.
Yeah,
All right.
good morning, Old Trafford's pressure. Gary Neville just
You just mentioned that it is 45 years. What happens when somebody you look at her, you look at everything pertaining to her, she's healthy, hardworking and everything, and below 40, and she has a colon cancer? What could have caused that?
Yeah, that's a great question.
Or secondly, what indication can give that person a sort of notification that, well, you are having something wrong with your colon or something like that? Because I can't just understand how a healthy person less than 45 could have a colon cancer, and how can she not recognize that something is happening? I just want to know that, please.
Yeah.
Before you answer that question, sir, if you're coming online to ask any question, can you let us know your name, please? So just for record purposes, thank you.
Well, thank you so much. My name is Shemi Adigun.
Thank you.
Thank you. Well, so when young people get cancer, I'll give you a little evolution of how this goes. When young people get cancer, they have, in my mind, one of two processes that are a problem. They either have a genetic predisposition to cancer, and that doesn't have to always be passed down from your parents, right? I have half my father's genes, I have half my mother's genes. The mixture, I don't know. But if my mother or father or my sister or brother or my son or daughter has early onset advanced polyps or colon cancer, I can use that as a playbook saying, okay, I probably am at higher risk for having colon cancer. Even without that playbook, you can have genetic mutations. These are called, in the Latin, de novo mutations. So you get a mutation just by virtue of your mother or father's gametes, which is the DNA that you get as a child or as a baby when you're conceived. There is a mutation in those. So that's one set of it. And we'll call that genetic, right? You have a genetic predisposition to cancer. The other one is environmental. And I think a lot of what the increase, and there is a traumatic and dramatic increase in colon cancer in young people in America. It has to do with environmental exposure. And whether that's the processed food we eat, whether it's the microplastics in the water we drink, we don't know. We don't know. But we know the symptoms. And the symptoms are, and I'll list them later, bleeding, changes to your stool habits, the consistent urge to go to the bathroom, tiredness. And those are kind of the vague symptoms, and sometimes not vague symptoms that you have to look out for. Those can sometimes be difficult to communicate to people at the access of care level. But I'd encourage you to advocate for yourself if those symptoms are present. And we'll cover that a little bit later in the lecture too. Did that answer your question?
Thank you for that information, sir. But at the same time, you are saying something about the symptoms. I still don't understand how the symptoms will affect individual. Either you are below 45 before you can have the opportunity to do a colonoscopy, or when you even do a colonoscopy, the colonoscopy says, oh, you have only a pop or two, and it's non-cancerous. And down the road, it comes up. So now you mentioned about environmental symptoms. If it's environmental that causes all this, once it's not genetic, okay, and it's now environmental, what can someone do, or what can someone keep an eye on, especially for our little kids that are just coming up, like 30-year-old, 37-year-old, and all that?
Yeah, I mean, I think you have to do it by symptoms. Now, if you've had a colonoscopy prior and you have polyps, then that's not what you're asking me, right? You're asking how does a 37-year-old know that they have colon cancer when they don't have a familial tendency towards that?
Correct.
Is that right?
Correct.
Yeah. And that is by keeping an eye on the symptoms. You have to have a low index of suspicion. Yeah.
Okay. Thank you so much, sir.
Yeah. Yeah. So just on that same token, we talked about the prevalence of colon and rectal cancer, and this story on the right, and this kind of diagram on the left tell you what a big problem colon cancer is in young people. And I think what will happen is we will drop the age again for colorectal cancer screening to 40. And I hope that we do that. So you can see I got this article here on the right side this week in December 4th about clinicians are struggling to understand the dramatic rise in early onset colon and rectal cancer. And that's what's going on in America. It's about 2% rise per year. And so if you take that over, many years, that's a 20, 30, 40% rise. And that's a problem. These are the symptoms of colon cancer. These are the symptoms you need to have a low threshold to investigate. Weight loss, abdominal pain, changes in your stool habits, mucus. It's a white slimy stuff in the stool, tired, lack of energy, blood in the stool. You can even have colon cancer with no symptoms, and that's why we do screening. Here it is again. When do you get screened? 45 to 75. That's you, and the interval of your screening depends on your judged risk. So if you have a family history of colon cancer, you have a 5-year interval between colonoscopies. If you don't and you have no polyps, you have a 10-year interval. If you find polyps, and these are dysplastic polyps or polyps with genetic changes, your interval may be shortened to 3 years, depending on the size, 5 years, or 7 to 10 years. And so that's how we screen. The purpose of the screening is not to diagnose cancer, but to act on the polyps that will eventually cause cancer. And this is what a colonoscopy looks like. You can see this practitioner here. She has a mask on, a robe. You're kind of laying on your side. They don't show an IV. In America, we have patients sedated. You can see that she's seeing a polyp here. And this is all done by fiber optics. Here's a short video. This is a polyp. This is a snare. And this snare is kind of just cutting this polyp off of the colon mucosa. And that simple act prevents colon cancer in this individual. And that colon cancer usually will occur 5-6 years down the road. Here on the right, you can see the screening interval, depending on what size of polyps you found on colonoscopy. So you see that there's an initial screening colonoscopy, but if something is found, you then enter an interval for a surveillance colonoscopy, so where you're surveilled. And we're looking for more polyps. We're surveilling for more polyps. There are other screening tools for people at average risk. Average risk is not the person who's had polyps before. Average risk is not the person who has family history of cancer. Average risk is not the person who has blood in their stool. Those patients are at high risk. But for average risk people, there are multiple ways to do screening. Colonoscopy, flexible sigmoidoscopy. It's a shorter colonoscopy. This is not worth it. A CT colonography. This is where you have a CT done. after you do a prep and you have some air in your colon. Maybe you've heard of Cologuard. This is the DNA. This looks for cancer DNA in your stool. Or maybe you've heard of tests that look for blood in your stool, and that's what this guaiac test is, or FIT test is. The difference between the 4 methods on the bottom of this graph and the 2 on the top are the 2 on the top allow you to do therapeutic interventions during the procedure to prevent colon cancer down the road. The ones on the bottom only tell you that you might have a polyp. And so that's why we advocate for colonoscopy. Who knows what it will look like in the future? Right now, the United States is working towards a multi-cancer early detection blood draw. But again, this is looking at cancer. We're not in the business of looking for cancer. We want to prevent you from getting cancer by taking out polyps. That's the best way to prevent it. But this will be very interesting if we can do a blood test for cancer. So we talked about your risk. How do I know if I'm average risk or increased risk? And this tells you. Again, we all start screening at 45 unless you're at increased risk. And I've kind of gone over this a little bit. If you have bigger polyps, if those polyps are more advanced in their mutation pattern and therefore exhibit different features, that puts you at higher risk. If you develop polyps quickly, that puts you at higher risk. And usually it's one of these syndromes on the right in yellow that cause this this kind of mutate, or this kind of quick turnover or regrowing polyps quickly. And then there's family history. And family history, you know, many people don't know their mom or dad, but it's very powerful what happens to your parents, what happens to your brothers and sisters. You're at risk for that. You name it. Doesn't have to be colon cancer. Could be high blood pressure. Could be heart disease. Could be atherosclerosis. You know, all those things, they give you the playbook. And so it's up diabetes. These are all genetic things. And so they give you the playbook. You kind of have a layout of what you need to prevent, okay? How can I lower my risk? So these are the recommendations. Eat a plant-based diet. Limit your red meat and processed foods. Don't drink alcohol. Exercise. Try to be at your ideal body weight. Don't smoke. All right. Get vitamin D. And so those are the things you can do. And that doesn't seem like a lot, but it goes a long way. It goes a long way because your body already has enough trouble not making colon cancer, and you don't want to give it any more. So what happens when you get colon cancer? Usually, or rectal cancer, the treatments are different for the two organs, right? For colon cancer, you usually proceed to surgery first, and then you have chemotherapy afterwards. That's called adjuvant chemotherapy. Not everybody needs adjuvant chemotherapy. Only those patients with a lymph node that's positive for cancer, okay? And that acts as a surrogate. Some patients just get surgery, and then they enter a surveillance pattern. For the rectum, it's also a little different by stage. Some patients get surgery through their anus to remove the tumor and then close the area and surveillance. Some patients get radiation and then chemotherapy and then surgery. Some patients get chemotherapy and surgery. Some people get radiation and surgery. So I think what you can say is that as you look at the two, normally surgery is up front in the colon cancer and surgery is last on rectal cancer. In advanced cases, chemotherapy is last in colon cancer, and chemotherapy is usually up front before surgery in rectal cancer. So they're treated differently. The way you do surgery varies throughout the United States. Some people make an incision down the middle. This is called open surgery. That's how we've done it for years. Everybody is proficient at that, and it makes it. There's a lot of things good about open surgery. What's not good is it hurts, and it sometimes can lead to complications that affect you for the rest of your life, like hernias and things like that. We developed a surgical approach called laparoscopic surgery, and that's where we use little instruments through metal ports, like you see on the end of this robot, to manipulate the tissue and dissect it, and then you make a small incision to bring out the specimen, and then put everything back together. And a lesser share of surgeons practice that, and then still fewer practice robotic surgery. Although robotic surgery is growing because it is far superior than, I think, laparoscopic surgery and open surgery. We have multiple robots at Capitol Health, and they make surgery a delight for patients and surgeons alike. Before I get into this, does anybody have any questions? Let's stop, because this is kind of a new section. Anything in the chat?
Yes, I see somebody. BC Okoye said, what is the first thing to look out for, or something that indicates that something is wrong with your colon?
Yeah, these are the symptoms you need to look for. Now, I wouldn't jump if I were, because I know, or maybe just because you have blood in the stool doesn't mean you have colon cancer. It could mean you have hemorrhoids, right? It could mean other things still. But these are the symptoms that need to be brought up to your primary care physician when you have them. And then they need to be investigated, usually with a colonoscopy. Certainly blood in the stool is not even subjective. It's an objective measurement. When you see that, that needs an explanation. If you haven't had a colonoscopy, you should get one. Other things like abdominal pain needs an explanation too. It can't be just dismissed. So these are the symptoms you need to look out for.
Okay, that's the only one there. That's only one question.
Okay, great. So this is the robotic approach, and what you see here is on the left that's where the surgeon sits. There's yellow and blue pedals. There's a pedal on the left. They help control the functions of the instrument, and then underneath those two eyes are places where we put our hands and manipulate the arms of the robot. And you can see the robot on the right-hand side. And there's 4 arms on this robot. The arms just work like your arms. You put it through the abdominal wall like this with a port, and you're moving anything you want, just like you would your own arms. And it's really neat. This tower in the middle, that controls some of the electricity to things. And the camera. The camera on the robot is just exquisite. It's beautiful. So it is very sharp, crisp, and in 3D. So I wanted to show you what it looks like to operate with the robot.
Something that you're not easily identify and control with the scissors.
Sorry.
Again.
Let me turn it. So you can see this is what the robot looks like when you operate with it. Now, the purpose of me showing you this is to show you that how safe it is, how nice it is. If you can see my cursor, this is the right plane to be in. And you see this picture on the right, you're going to see this coming up. We've injected the structure that carries the urine from your kidney to your bladder with a dye, with an infrared dye. And so now, as we're going to do this surgery, which puts this organ, which is called the ureter, at risk, we can then see this structure by simply flipping over the infrared camera. And I just kind of stopped it before I should. I'm going to let it play and just be quiet for a second. And here comes the flip over, and now you can see the structure. And so that makes it safer. That can be injured during surgery, and it's a whole rigmarole if it is. Let's see. How about, let's see if this will play for us. How about bowel perfusion? So here we are, we're using a stapler to divide the colon. And you saw at the beginning of that green light again. We've injected this dye into the vein, and it shows us that the bowel has blood flow at this location. And of course, blood flow is very important to making something heal. And there's the staples. The other thing we do well at, especially all colorectal surgeons really, but also at Capital Health, is, we do a good job of extracting the entire specimen, all the lymph nodes. Remember, we talked about in the beginning the rectum and the mesorectum. What you see here on the left is you see not only that yellow fat-covered rectum, but you see all the mesorectum there, all the lymph nodes coming out. This is important. Your surgeon needs to do this well. When you find a surgeon, make sure they do this well. And that can be hard to do. Here on the right, you see the colon specimen I showed you earlier. This contains all the lymph nodes. This is not a small specimen. And this kind of surgery is called a mesocolic excision. And you can see that it's shiny on the back, it's shiny on the front. These are important aspects to take into account when choosing a surgeon. These are done robotically. I think we do them very well. My partner is exceptional. This is outside of your rectum is our other lymph nodes. This is not done everywhere. This is called a pelvic lymph node dissection. This will not, most institutions will not offer this to you if you have a low rectal cancer. We can do this, and we can do it robotically at Capital Health. This is a big deal. It took me years to learn how to do this, and it's very important at decreasing local recurrence after cancer, meaning patients who have cancer, they get treated, and their disease comes back, and they come back in these lymph nodes. And this is what the patients look like afterwards. They have small incisions. They are up and about. It takes about 2.5 hours to do this surgery. And patients are drinking the same day, they're walking the same day, the next day they're eating and usually going home. The same goes for the left side. I mean, these are tiny incisions compared to where we were years ago, 10 years ago. And then if you look in the blue, the complication rate just keeps going lower and lower as we progress with robotic surgery. So it's much better, in my opinion, than
question.
So I wanted to thank you guys for listening to me today. I'm going to field all questions at the end. I appreciate your time and your attention. I hope you learned something. I think the most important thing you can do is say, if you have a problem, get a colonoscopy. And you guys, all your questions were geared towards that, and that's exactly what we need to do. And then happy holidays. These are my kids. Yeah. All right. I'll open the floor to questions.
Okay. If you have any question, you can send it through the chat or you can raise up your hand.
Well, if I can raise up my hand, can I raise up my voice?
Hello?
Yeah. Hold on. Yeah, go ahead.
Okay. Can I raise up my voice because I don't know how to raise up my hand?
You guys hear me?
Yeah, go ahead.
Okay.
Oh boy.
Thank you, Dr. Is it Dr. Berry? Is that right?
Let's see if I can.
I don't think I hear.
Can you hear me?
Huh?
Yes.
Yes, it is.
Okay, Dr. Berry, can you hear us? There's something wrong with this. Mr. Koya, I don't think this man can hear us.
Can you hold on 1 second? Is on.
Dr. Berry, can you hear us?
Hello?
Maybe it's mute.
Thank you for your time. Does anybody have any questions?
Yes.
We have questions, sir.
Any questions?
Yes, that's a
All
question.
right.
Yeah, go ahead. Hello?
Okay.
Thanks for all you do for the community, and thank
Hello?
you for allowing me to present today. Have a
Hello,
great
Dr.
day.
Berry.
Dr. Berry, Maxi Low.
Hello. Hello, Dr. Berry.
It has a problem. The
Hello?
network is not working.
Oh, good.
I think it's muted. So
Hello, Dr. Berry.
It's not that. I think it's
Can we
network is
unmute
as
everybody or unmute people or?
Hello.
yeah, well,
Write it
hello.
in the
Yeah,
chat.
you are muted, but you are not muted. We can't hear you.
We can't hear you. Hello, Dr. Berry.
Oh, I'm trying
Maybe
to.
you should write it in the chat.
Hello?
Oh, I'm good now. I
Okay.
muted the computer for the
All right,
video.
go on, TJ.
Okay. Okay. Well, Dr. Berry, let me first of all thank you. My name is TJ Abbas. I am also a cancer patient. I really want to thank you for coming out today. And I don't think there's any amount of money that will compensate for the information that we have all received today. I'm sure before you came in, we were not as informed about either colon cancer or rectal cancer or any kind of cancer, even though it's a very personal and emotional disease to some of us. But living here today, I think will be very much, we'll go back home with all the necessary tools you've given us that will ensure that we live a very healthy and healthy lifestyle. My question to you, sir, is that there are a couple of screening procedures. I don't know whether they are related to colon cancer. I know you talked to us that you cannot, there's no blood work that will be able to detect colon cancer or rectal cancer, but can a body scan or a PET scan, can they detect colon cancer through a body scan, a whole body scan and a colon and a PET scan. Is that possible?
Yeah, it is possible for sure. All right. So the limits of PET scan are anything less than 1 centimeter in size. So that can be difficult to find. Now, PET scan detects cancer. I would much rather, TJ, find your cancer before it even becomes cancer. Truthfully, I mean that's my mantra today, which is
Prevention.
go get a colonoscopy, make it preventative. Do not become sick. Do not have these problems. You know, and I do a few colonoscopies. This is not about this is about your health, getting to the right people at the right time to make sure you don't get cancer. A PET scan can be very useful if you have cancer, especially if you have metastatic cancer. And you know what a PET scan does is it detects metabolism of glucose, right? So typically some glands and some cancers metabolize glucose at an increased rate. And so that's what a PET scan does, right? It says, hey, this area here is metabolizing glucose quickly. And sometimes that's this big and sometimes it's this big, but that's what it detects. And so we assume that's cancer, but we don't know that. We have to biopsy it typically.
Okay. What about the body scan?
Are you talking about a CT scan?
No, they call it a body scan. It's a complete body scan, comparable to the PET scan, but I think it also goes on to detect any signs of cancer in your system, you know, particularly when it's metastatic. Is that what you call it? Yeah, you know, they want to check whether it has gone to other parts of your body. The body scan.
So let me ask you a few questions. I don't know exactly what a body scan is. Are you talking, is that different than a CT scan?
Is that what it is? Maybe it's a CT scan of the entire body. Maybe that's what it is.
Okay, yeah. Okay, a CT scan. So your question is, can a CT scan detect cancer?
Yeah.
The answer is maybe.
Okay.
So depends on what you do during that CT scan. So let's just say you have a CT scan from your head to your toe to detect cancer. There are a couple things you have to do to improve the sensitivity of that test, which are IV contrast and oral contrast, or if needed, rectal contrast through your anus to look at those things. So one version of that is what I wrote, or what I put up on the chart, which is CT colonography. So I guess one question would be, how good is CT colonography at detecting colon cancer? And the answer to that is above 95%.
Okay.
But in terms of doing a whole body scan and looking for cancer, that can happen, but you're going to have the person that comes back with cancer there is going to have some advanced cancer. And you're also going to find some things you that are not cancer that look like cancer. And so I think there's pluses and minuses to every test to increase the sensitivity. IV, PO, rectal contrast, or IV, oral, and rectal contrast is useful, but it's probably not the best test. Really, there are a few common cancers in America, or in American statistics. Skin cancer, you can imagine, from the sun. Breast cancer, that's looked at with mammography. Colon cancer, the ones we're not doing with colonoscopy, the ones we're not doing, and then prostate cancer, that's picked up with a blood test typically. The ones we are not doing well at are pancreatic cancer. And so we're trying to get a good solution for that. We used to have a lot of smoking. And so if you smoke, you should get a low dose CT scan at the age, I think it's the age of 50. And that CT scan will help pick up, that's a screening tool for lung cancer. Does that make sense? Those are kind of screening availabilities for the most common cancers. That's probably a better approach than a whole body scan.
Oh, seeing her, I can't believe I just saw it.
Is that, TJ, you feel good about that answer, or at least know a little more? Okay.
Hello, I have a question. I have a question. My name is Ayodele Oshilaja.
Hey, Ardell.
Okay. My question is about the pull-ups that you're talking about.
Mm-hmm.
You talk about the hydroplastic, and can you explain the difference between those two pull-ups?
Mm-hmm. So hyperplastic polyps are normal. They're normal tissue. They are like a scar. That area is working harder, and so it builds up more tissue there, mucosa. The polyps that are not hyperplastic, there are many variations of those. There is the adenomatous, then there is serrated polyps. This is seen under a microscope mostly. But those are the ones that have a specific genetic pathway. One's called the Vogelstein pathway. One's called a SSA pathway. Those genetic mutations then put you at risk for having cancer in both those kind of different polyp pathways. Hyperplastic polyps are normal. And that's why it's important to follow up after your colonoscopy. Just because somebody pulls a polyp off doesn't mean it's going to be dysplastic, right? Or on its way to cancer. It only means that a polyp was removed, and it has to be looked at by a pathologist to kind of determine if what that means, right? In terms of genetic changes versus just normal hyperplastic polyps. Yeah.
Thank you so much.
You're welcome.
Is there any more question? Okay, let me ask you this question. Is there a method to detoxify colon or rectum?
No.
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 Just drink a lot of water?
Well, I mean, I guess the way another question is there a way not to put toxins in your colon? And that can be difficult. But again, alcohol, tobacco, processed foods, those are going to be your main contributors to colon cancer. There's no detoxifying it. I think there's some value to fiber in terms of holding on to toxins. And that's a fiber supplement for most people. Just depends on your diet. But the fiber I recommend to people is psyllium husk fiber, which is just corn husk. And that does have some ability to trap toxins. But there's nothing you're going to do to kind of like, other than that, that's kind of the extent.
Okay, thank you so much, Dr.
Welcome.
The president of the Eko Club Philadelphia want to say one thing or the other to the public, or to thank you as well. Honorable Bisi Okoya, please.
Oh, sorry about that. Thank you again to Dr. Berry And to everyone that log in, I hope we are all able to learn one thing or the other. Eko Club is a non-profit organization, and we're able to get these doctors, and I hope more people log in again. And all we do is volunteering, giving back to our community. We do scholarship for high school seniors that are going to college. We go to Ronald McDonald's, volunteer there. We do highway cleaning. We adopt highway, and we do free turkey for underprivileged people or the needy people. And we do free winter clothes, coats for the needy people too. So please support our cost. And the next program coming up is going to be in January. We will let you all know about it. Thank you again. This is Eko Club Philadelphia. Thank you to everyone and to Dr. Berry.
Okay, before we can let you go, I just have some information here for most of our listeners. This is we've been doing this as health education. We are not only on health issue only. If you know any speaker in other areas, whether it's law, immigration, investment, real estate, insurance, where this is bringing it to the idea of most of us here who doesn't know. Some people are just only one way, but hearing information from the expert give us the opportunity to learn more. So if you know of any speakers in these areas, please reach out to us, to our PRO, Honorable Shadi Adedeji at 201-407-181, or email us to Eko Club Philadelphia at gmail.com. I'm going to tag it in. If you know anybody, please reach out to us or reach out to any Eko Club members. They will pass the information to us. That being said, I'm going to call our grand patron. I think the speaker, Dr. Berry, you're already familiar with the person. TJ Abbas, can you give us a very last word to thanking most of our members, especially Dr. Berry? Thank you.
Oh, thank you so much. Even before I said, I was thinking if there is a way that we can also consult with Dr. Berry. Although I live in Nigeria, I also live in Houston. Some of us are Medicare patients. We have our Medicare insurance. So I'm sure we have that latitude to go any part of the country and consult with anybody that we feel that we want to consult with. I believe so. And Dr. Berry, from what we have gathered today, no doubt is on top of the game. So if there's some information that can be passed around to the platform about his phone number, so maybe his office that we can call and reach out to him for more information, particularly some of us that have insurance. So on that note, let me thank every one of us who have logged in. Let me thank the president and members of the Eko Club Philadelphia for what they are doing. This is a huge project. Information is the key, no doubt about that. And I've been able to attend the last 3 prostate sessions, and it's been quite informative. And I'm sure all of us living here today, we will live here today with all the necessary tools, armed with the knowledge about what colon and rectal cancer is all about, to ensure that we live a very healthy lifestyle. They said awareness is the greatest weapon, and the early detection is also our shield And most significantly, the collective action of every one of us here today, from the information that we have gathered here today, will enable us to live that. So, Dr. Berry, I thank you for your time. I thank you for the information you've given to us. It has been quite instructive. I don't think there's anything that we can give you that will compensate for your time, except to ask God to continue to be with you and your family. So we really appreciate you, sir. It's been quite a session here today. So to all of us that are online, that is the key. We're now getting to the point in our life that if you look back to some of the things that we've done during the early part of our life, if we have to do it differently, I'm sure we'll do it differently. I used to smoke. I used to drink a lot of wine. I used to drink a lot of 1738, but I can't do that anymore now. So some of us can still learn a lot from that. So, Dr. Berry, thank you. God bless you. It's been quite a session here today.
God bless all of you. Have a great holidays. Thank you so much for the opportunity.
Thank you so
Thank
much.
you, sir.
Thank you. Happy
Thank you,
holiday
sir.
to
Happy
everyone.
holiday. Thank
Happy
you.
holiday.
Thank you.
Thank you, sir.
Bye, guys.
Bye.
Okoya,
Thank you.
Yes.
Okoya and Co.
Yes.
Thank
Thank you so much.
Bye.
Thank you
All
for
right.
inviting us.
Thank
Thank you.
everyone.
Thank you.
Happy
All right.
birthday.
We'll be looking forward
Any
to January 11.
January 11 is about your heart. We are coming
Okay.
back with a very
Heart
good one.
health.
Thank you so much. Madam President, Goma.
Oh, yes, ma. Thank you
God
very
bless.
much.
Bye.
Thank you all.
Okay.
Thank you.
All
Bye.
right.
I don't know.
Yameto.
Yes, I
Oh,
know. Yameto,
no.
I know your voice anytime.
Elema.